Welcome to this webinar organized by the Pulmonology Professional Community Network of ISHLT. I'm Lorenzo Zaffiri. I'm a lung transplant pulmonologist, member of the Pulmonology PCN, and also representative of the early career and training committees. My co-moderator and I developed this topic given the increasing relevance of connective tissue disease-associated interstitial lung disease. Here now is becoming an increasingly common indication for lung transplantation, yet remains one of the most complex patient population that we care across the transplantation. During the webinar today, we will explore this evolving landscape. We will focus on practical consideration with the goal to guiding the care for this patient with CTD, connective tissue disease-ILD, undergoing lung transplantation evaluation before and after. We are fortunate to have two experts today. One is from the United States and the other from Europe. They will share their insight and experiences. We decided to obviously try to have a different and variety and diversity of experiences. So we look forward for a robust and informative discussion. As a reminder for the audience, the preferred method for asking questions is through the chat, and my co-moderator and I will then direct the questions to the speakers. Thank you again for joining us, and I will leave Aida introducing herself and the first speaker.
Hello, my name is Aida Venado. I am a transplant pulmonologist at the University of California, San Francisco, and member of the pulmonary professional community at ISHLT. It is my honor to introduce my colleague, Dr. Andrew Gross. He is a professor of medicine and the director of rheumatology at the University of California, San Francisco, who will start with the first talk.
There we go, and there. All right. Everyone can see my slides. We're good. All right, perfect. Okay. Well, thank you, y'all, for inviting me to talk. I'm Andy Gross. I'm from the from UCSF, or the Rheumatology Division. And we're talking about rheumatologic considerations in lung transplant. I have way too much information to cover, so I'm going to talk fast. My apologies. So here we go. So two of the key things I want to address is how to determine if autoimmune disease is adequately controlled to undergo lung transplant, and what are the risks of immunosuppressive therapy for autoimmune disease post-transplant. And some of the diseases I'll cover are rheumatoid arthritis, myositis, rapidly progressive ILD, MDA5, and scleroderma briefly. So we'll start off with rheumatoid arthritis. So Mr. Mann, 59-year-old man, was diagnosed with CCP positive rheumatoid factor positive erosive rheumatoid arthritis 7 years ago, treated with methotrexate. Sorry, he was still somewhat active with that. 5 years ago, he developed a dry cough and dyspnea and found to have a UIP pattern ILD, which continued to progress despite treatment with mycophenolate, so he's referred for transplant. So thinking about what's the status of his rheumatoid arthritis, how do I assess if his rheumatoid arthritis is active, and will that be a problem post-transplant? Okay, so I'm going to go through this quickly since I think since this is very straightforward to any rheumatologist, and for the pulmonologist, you're going to say, well, let the rheumatologist do it. But basically, the way we do rheumatoid arthritis disease activity measurements is we calculate a score based on the examination of the patient, as well as a patient global and a physician global often. So all we're doing is just pressing on the joints and figuring out if the patient, his joint is tender, if the patient is reporting it hurts, as well as if I feel synovitis, so if I feel swelling kind of coming out of that joint. And we do that for the PIP joints, the MCP joints, the wrists, the elbows, shoulders, and the elbow and the knees. And then we put this into a calculator. There's a number of different kinds, but a very commonly used one is called the DAS28. And then we get a score. And then the score stratifies patients into remission, low, moderate, or high disease activity. So that's how we assess disease activity in rheumatoid arthritis. And the goal of this, of course, is to reduce joint inflammation, pain, and prevent damage. Okay, so then how do we do that? So we're using a treat to target strategy. This is based on American College of Rheumatology and EULAR guidelines. Um, and so thinking about this in the context of transplant, does it matter? Does it matter if we achieve lower disease activity? And the answer is we don't know. There's been no good studies to see if outcomes change with better rheumatoid arthritis disease activity. Pre-transplant, there is some data that worse disease activity, rheumatoid like joint inflammation, is associated with a worse prognosis in patients with RA-ILD. So generally, it seems like it's a good idea to control disease activity. Not to mention, it just hurts to have a really active rheumatoid arthritis, and people are in a catabolic state to some extent. So it just is intuitive that you'd want to maintain rheumatoid arthritis disease activity post-transplant. Um, so how we do that, I'm going to go through this briefly. Pre-transplant and without ILD, we're going to start methotrexate or leflunomide. Um, we don't tend to combine that with mycophenolate. So if patient's going to be started on mycophenolate for the ILD, often we'll stop the methotrexate or leflunomide. We'll then assess the disease activity 3 to 6 months later. And again, if the patient still has that moderate or high level disease activity, then we're often going to add a second agent, usually a biologic DMARD. The most common ones, of course, are the anti-TNF agents, but sometimes we use abatacept, CTLA-4 Ig, tocilizumab targeting IL-6, rituximab, of course, targeting B cells, CD20, and then we often lately are using JAK inhibitors, which of course are not biologic DMARDs, they're small molecules, but tend to be quite effective for treating RA. Okay, so thinking about this post-transplant, are medications used to treat rheumatoid arthritis good or bad? Okay, so in a single center study of patients with autoimmune disease undergoing liver or kidney transplant, biologic DMARDs to treat autoimmune disease might increase the risk of serious infections. So this was primarily patients with inflammatory bowel disease treated with anti-TNF agents, and they did see a higher rate of infections in patients on the biologic DMARDs compared to matched controls. And one of the most common serious infections were UTIs. So these were generally manageable infections, but there was a higher rate. On the other hand, somewhat surprisingly to me, there was no increased risk in opportunistic infections. So it seems to me this is a manageable risk, but it is a risk. On the plus side, is there any benefit to being on these biologic DMARDs? And there might be. So biologic DMARDs for RA have been shown to be effective for preventing or treating post-transplant rejection. So some examples are belatacept in the kidney transplant literature, and even abatacept has been shown, the drug that we often use for RA. Rituximab, of course, has been used to help prevent rejection and has a role for that, but of course it is complicated by a higher risk of infections in some studies. Tocilizumab, there's actually data in the lung transplant recipients for preventing antibody-mediated rejection, and there didn't seem to be an increased risk of infection, so that might be a good option post-transplant. And then finally, JAK inhibitors have been used to try to prevent rejection, but these studies have been complicated by serious viral infections, so it's not been pursued. So those are sort of some of the ways I think about our options post-transplant of managing rheumatoid arthritis activity. I think certainly these are immunosuppressive medicines, so they do likely do increase the risk of infections, but I think that's probably a manageable risk, and there may even be some benefits to using these drugs post-transplant. So that's the story with rheumatoid arthritis. Let me move on to myositis-associated ILD. What am I doing here? Okay. So Miss Guy, 41-year-old woman, previously healthy, who was diagnosed with antisynthetase syndrome, NSIP-OP overlap on chest CT. Despite treatment, her disease has remained active and has progressive lung fibrosis. She's referred for lung transplant. Okay, so how do I think about monitoring people's disease activity with dermatomyositis pre and post-transplant? So there is a technical way to do this and more used for clinical studies called the total improvement score. I'm not going to go into all that because it's not something we routinely use in clinical practice. Generally, in clinical practice, we're just going off clinical signs of dermatomyositis. So let me show you some examples, which many of you are probably very familiar with. So, of course, the Gottron's papules, these violaceous pink or purple rashes over the knuckles, as well as the ragged cuticles. You can have a malar rash, sparing the nasolabial fold there. You can have the heliotrope rash, which sometimes has erythema and just has swelling around the eyes. And then, of course, you can have mechanic's hands with that hyperkeratosis over the palms and sides of the fingers, often with cracking. So those are the rashes I'm looking out for as sort of a sign of dermatomyositis activity. Switching slightly from classic dermatomyositis to antisynthetase syndrome, which of course in the lung transplant world we're going to see even more of because it's especially associated with ILD. But some of the other manifestations of antisynthetase syndrome are of course the mechanic's hands I just showed, looking for that activity. Myositis, although this tends to be quite mild and easily missed in antisynthetase syndrome. Raynaud's phenomena, that tends to just be present all the time. It doesn't tend to so much vary with disease, but it can. Um, Arthritis, this is a dead ringer for rheumatoid arthritis. People can have a ton of joint pain in their hands and sometimes fevers. And then, of course, the typical autoantibodies are associated with this condition. But these are some of the key things I'm looking for as signs of antisynthetase activity, especially the mechanic's hands, and then more subtle signs of myositis. Okay, so how do I assess for myositis? Um, well, of course, the starting point is a physical exam looking for muscle weakness, but of course, that can be challenging in different patients depending on their previous muscle bulk and age and so many different factors. So I try to work off the physical exam to some extent, but it's a lot of uncertainty there. Biomarkers are helpful, the creatine kinase and aldolase, although, of course, in antisynthetase syndrome with very mild levels of myositis, frequently these are normal even in the presence of low-level myositis. So one of the things that actually our group finds very helpful is actually MR imaging of the muscles, especially the thighs or the deltoids and upper arms. You can do an MR without contrast, and you get it nicely picks up whether there's edema of the muscle suggesting myositis activity. So we end up falling back frequently on that if there's uncertainty from lack of data from these other measures. Okay, so thinking about transplant, what do we worry most about? Like, who are the people that we have to really worry about in the post-transplant? And I really like this study published a couple of years ago showing survival post-transplant really was a whole lot worse in people with classical inflammatory myositis rather than amyopathic myositis. So people with lots of muscle inflammation and as well as potentially active rashes really were problematic. And so that really emphasizes to me the importance of controlling muscle inflammation going into transplant. We don't have as much information about the importance of controlling rashes or arthritis going to transplant. Okay, so then the challenge, of course, is finding the correct cocktail of medication, immunosuppressive medications, prior to transplant to control patients' disease, and not just their lung disease, but of course their muscle disease, their joint disease, and their skin disease. And if we have time, we'll come back and talk a little bit more about that. Typically, it's necessary to continue these immunosuppressive medications post-transplant to maintain control of the muscle disease, the skin disease, and potentially even the lung disease. So whatever we're doing pre-transplant, we're probably going to continue on post-transplant, very similar to rheumatoid arthritis. Okay, got 6 more minutes. All right, so I'm blasting through. All right, so I want to talk a little bit about rapidly progressive ILD. This is what, of course, we all fear. It's hard to find data on the different diseases that potentially cause this. We've all seen different diseases cause it. But the disease that we worry most about is MDA5 disease. So example here is Ms. Ng, who's 35, previously healthy, developed shortness of breath and cough just 3 months ago. Her shortness of breath and cough has progressed so much that she showed up in the ER with requiring 6 liters per minute of oxygen to maintain low O2 sats. Chest CT shows overlap OP and SIP pattern ILD. Okay, so MDA5 disease. So the key things here is looking for the classic skin rashes to pick this up early. And the classic skin rashes are on the palms, unlike I showed you the Gottron's papules over the knuckles previously with classic dermatomyositis. MDA5 tends to have more of these little ulcerating lesions on the palms over the creases of the fingers. Very, very typical. So these ulcers, and so you're looking for ulcers. Sometimes patients can have mechanics hands as well as classic dermatomyositis rashes, including the heliotrope and the malar rashes. Frequently, these patients are amyopathic or have just mildly elevated CKs, and it's not uncommon for them to have fevers, arthritis, and of course, they have the MDA5 antibody. Well, a lot of work has been put in to try to stratify these patients and try to categorize them to identify who's most at risk for that rapidly progressive ILD. And there's been a few different studies doing this. They all show similar things, which is it's challenging. Patients with the most rapidly progressive ILD here, cluster 3, tend not to have as much as an exuberant rash as some of the folks with the more mild lung disease. They tend to have relatively mild muscle disease. And at least in this study, they claim that patients had the highest titers of MDA5. I know at UCSF, it's hard to get an MDA5 titer, and I don't know about other institutions. I know this is more commonly done in China. But what they showed in this group, in this cluster 3, is that they did not do well. So actually 60% of patients in this cluster 3 died in the first 12 months. So with many of those deaths coming in the first 3 months in this orange bar. So this is obviously extremely scary. So how do we manage these folks? Well, we throw in everything but the kitchen sink. So it's not uncommon, of course, to start off with high doses of glucocorticoids and then take your pick. I think, unfortunately, right now, all we have is a whole mess of observational studies giving slightly conflicting data. And so in my mind, I still really don't have a good feel for what's the right cocktail of medications to get this disease under control. I've listed out a whole bunch of different medications, and depending on what center you're at, you probably have your own favorites. I think one of the things that we're seeing more and more of is quadruple therapy, where you choose the glucocorticoids and 2 of these drugs, and then even add in a JAK inhibitor. The scary thing about that is that there's a nice paper recently from China showing that with the addition of that JAK inhibitor, there might be better disease control, but that placed patients at much higher risk for infections, especially viral infections. So it's a difficult balance trying to figure out whether to to really load up and try to control these patients' disease at the risk of serious infections. As I mentioned before, there's a lot of interest in MDA5 levels. So there's a case series of patients looking at them undergoing lung transplant, and in these 2 studies, it seems the patients with MDA5 seem to do well post-transplant. I'm a little bit skeptical of that data, I think, based on our own experience at UCSF. I think time will tell to see how well and what are the correct prognostic features for these patients and deciding whether to pursue transplant. But there is some data that patients with much higher MDA5 titers don't respond as well to treatment. And so I reluctantly give the suggestion that if you can get an MDA5 titer, if it starts off very high, you should be concerned. And following treatment, if that titer doesn't come down, there's some data to suggest that that's really a problem. including from this group, from the SATO group. So I think more to be learned about how the utility of MDA5 titers, but it's something certainly to pay attention to. Okay, last 2 minutes. Miss Call is a 62-year-old woman who developed Raynaud's 6 years ago. Then she developed progressive tightness over her hands and face, spreading to her arms and chest. Diagnosed with diffuse scleroderma, found to be SEL70 positive. And of course, we know SEL70 is associated with bad lung disease. That's progressive. Sure enough, she had a baseline chest CT showing fibrotic NSIP and a low FBC. That's a bad prognostic sign. And despite treatment, ILD progressed and she's referred for transplant. Excuse me. So when I think about scleroderma, I kind of think, so many different manifestations of scleroderma. So this is the way I kind of keep it, kind of track of everything. I think about the fibrotic aspects of the disease. I think about the vascular aspects of the disease, and I think about the inflammatory aspects of the disease. And especially I think about the inflammatory stuff because that's what's going to respond best to immunosuppression. Vascular will not respond to immunosuppression. Fibrosis, it's a little bit mixed. So with fibrosis, I'm thinking about the skin, that might respond to immunosuppression, and then the GI tract, which does not. And that's, of course, the esophagus, lower GI tract, and then, of course, the vascular, Raynaud's, pulmonary hypertension, and scleroderma, renal crisis. And then finally, on the inflammatory side, interstitial lung disease, myositis, and arthritis. So last slide. So thinking about scleroderma considerations going into transplant, I think about immunosuppression being important to control progressive skin disease. Frequently, by the time someone gets to transplant, their skin disease has stabilized, and it's not as much of a priority to continue immunosuppression for that. There are some patients with the myositis overlap, especially people with these autoantibodies. One has to be careful about that because then we're back into the myositis paradigm and needing to continue immunosuppression post-transplant. And then, of course, myocarditis is a feared complication in scleroderma, difficult to manage, but sometimes also needing continued immunosuppression. Things that don't respond to immunosuppression, the GI manifestations, as I mentioned. So these are things that are important to work up and identify because of the poor prognosis associated with them, especially the lower GI involvement in malabsorption with weight loss. But these are things that we're not going to immunosuppress. Scleroderma renal crisis, of course, is really important to identify patients at risk, especially with that RNA polymerase III antibody, and to be mindful that even post-transplant, we've seen that. And then finally, Raynaud's manifestations can be a problem post-transplant, but that we're going to manage with vasodilators, not as much of an issue in managing a person's lung grafts. So that is my whirlwind tour of rheumatologic considerations in transplant. I'll leave it at that.
Perfect. Thank you, Dr. Gross. That was fantastic, and thank you for reviewing so quickly a lot of different diseases.
My apologies for the speed.
We gave you a big task. It's my pleasure to introduce now Jérôme Lepavec. He's a physician and scientist affiliated with the Hôpital Marine Lanelon in France. He's gonna give us a talk about comprehensive management of lung transplantation for patients with connective tissue disease associated ILD. Thank you, Jérôme.
Yeah, thank you, Lorenzo. Thank you, everyone. Do you see my slides?
Yes.
I think so. Okay, thank you. So yeah, it's my great pleasure and a huge honor to be here with you today. So I will be talking about comprehensive management of lung transplant for CTD-associated ILD. So I will focus on three main parts. After a short introduction, we'll discuss the way we can select our patient, what would be the peri-operative management, and a few words on post-operative outcome. So first, let's talk about epidemiology. And as you know, there has been a significant increase in the number of lung transplant over the last 30 years. However, the number of CTD patients that are transplanted currently remain pretty low. less than 1%. So we will be talking now about 50 patients transplanted a year, which remain quite limited. A few words on our centers. We've been transplanting patients for 40 years now. And in France, as you see on the right part of the slide, there are now nationwide healthcare networks dedicated to pulmonary rare disease, in which patients with CTD are managed. And based on this organization, Marine and Long has structured its clinical activity around this specific area of expertise, allowing us to transplant 5 to 10 CTD patients a year, representing around 15% of our activity. So few words, remembering everyone that we are talking about a group of autoimmune disease, in which scleroderma is mainly the most represented patients in the field of transplantation. Although I was asked to talk about ILD, please note that PAH and PH or PH-ILD remains strong indication for lung transplantation. And you see on the right that our most important indication for transplantation in Marine and Long is still scleroderma among the rare disease and CTD patients, and mainly for PAH or PH-ILD. So apologies, but I will also talk about a lot of scleroderma and PAH and PH-ILD in addition to ILD. So how do we select our patients? So two challenges we will be facing. The first one, as you've heard about, is the fact that this is a multi-organ involvement disorder. This is still in some centers a relative contraindication for transplantation. And this is because there are concerns that these pre-existing extrapulmonary conditions would impact the post-transplant outcome. A few words on the use of antifibrotic drugs, and there is now a widespread use of these drugs in our ILD population and also in the CTD population. And maybe these drugs would increase the age of our candidate transplant and the potential severity at the time of transplantation. So apart from these two challenges, when should we consider the transplantation project? So when there is a high risk of death within the 2 years in the absence of transplantation, and this is true for the most breathless patients. Keep in mind that some clinical phenotypes are associated with a high risk of life-threatening acute respiratory failure, and this is particularly true for PAH and fibrosis. Some patients will also spend a longer time on the waiting list, depending on height, HLA, the surgical procedure, or the blood group. At the time of your evaluation, you may also identify some clinical condition that may improve or could improve before a lung transplant. And it's also essential to avoid the most emergent situation and the need for transplantation under high priority, because it's really hard in terms of workup and in terms of management. So that I would say evaluate your patients as early as possible. The listing criteria in CTD patients are not specific. So depending on what would the respiratory phenotype be, your decision to list this patient will rely either on the PAH criteria or on the ILD criteria that were recently updated in 2021. Few words on some additional phenotypes that you know maybe patients with PVOD form or PH-ILD will carry the worst prognosis in the absence of transplantation. So maybe they should be referred and listed pretty early. A few words on the specific evaluation you will have to deal with in the context of connective tissue diseases. And here again, based on the example of scleroderma, you will be looking at several compartments. On the renal level, you will be assessing the risk factors for the systemic renal crisis. The most one being the presence of anti-RNA polymerase III antibodies. Regarding digital vasculopathy or skin, you will assess the renal phenomenon severity and the presence and the number of digital ulcers over the last 12 months. Regarding the GI tract, which is quite challenging, you will be looking at the presence of GERD based on a 24-hour dual pH probe study and ideally an impedance testing. You will also look at the presence of any esophageal dysfunction based on the CT chest, which may show some form of esophageal dilatation or the presence of air fluid level. You will also look at the manometry and if there is any signs of aperistasis. Looking at the stomach, you will also try to identify the presence of gastroparesis based on the gastric emptying study. Nutritionist evaluation is also welcome in terms of nutrition state and the need for optimization or rehabilitation. You will also communicate with the surgeon, depending on the center, who could be a thoracic surgeon or a digestive surgeon, to evaluate the need for any reflux surgical procedure during the pre or the post-operative time. You will also check the cardiac system based on echo and cardiac MRI if any signs of restrictive cardiomyopathy or suspected myocarditis. And you will also perform left and right heart cath with fluid challenge. No specific consideration for CTD patient in terms of absolute contraindication that everyone knows here. You will be ruling out any form of cancer. Particularly in this situation, you will be looking at any extrapulmonary organ dysfunction and so on, as you know. In this context of CTD patients, and again in scleroderma patients, regarding kidneys, transplant won't be reasonable in the absence of combined lung kidney transplant if they have a poor renal function, as stated here. Regarding the fingers and the skin, having an uncontrolled non-healing ulcers is also considered as a contraindication. And so this is in the presence of skin thickness and pending rehabilitation. Regarding the GI disease, you will focus on identifying three main contraindications: having a severe swallowing dysfunction, having an underlying and significant esophageal dysfunction, which the definition can be discussed here, but in the consensus, we proposed that it was the definition was having a complete aperistalsis in addition to GERD, not surgically salvageable in the post-transplant period, or having patients with an unwillingness to receive enteral artificial nutrition. And last, having a severe symptomatic gastroparesis as defined by a nuclear medicine gastric emptying test of more than 35 retention at 4 hours despite maximal therapy. And regarding the heart, you may require a heart-lung transplant in the presence of either a myocarditis and or a refractory systolic heart failure. So let's move to the perioperative management. Once your patient is listed, what we do in France is that we are following them very closely. We see them every 3 months during the consultation. We will be looking at the nutritional status, any presence of frailty signs, any need for rehabilitation. We will also obviously look at the extrapulmonary involvement, any signs of GERD, any clues for aspiration, any recent digital ulcers, and in what severity, what is the renal function. We'll be checking the HLA antibodies. And more importantly, we will be looking at the presence of any additional signs of the respiratory deterioration, suggesting maybe a need for an urgent transplantation. And this evaluation will be made based on a regular communication with the referring team. Few words on the allograft selection. Because on one hand, you may have a small cavity, a small chest cavity due to the fibrosis, and maybe you will face difficulties choosing your allograft, exposing your recipients to an oversized allograft and a size mismatch, increasing the risk of PGD. However, there are several complex formula that will help the clinicians to choose the best size based on the predictive TLC, which should be comprised between 75 and 125% of the recipient TLC. On the other side, maybe your patients will have pulmonary hypertension, and based on that, you will have to choose an allograft with adequate pulmonary vascular bed to minimize the right ventricle failure risk. So how do we deal with this paradox? In Marine Long, we have a recent approach described here. We are transplanting an entire lung on the right, and we chose to transplant only a lower lung on the left. So it allows us to close the chest just after the surgery with an acceptable risk in terms of pulmonary tamponade and right heart failure. So this approach is pretty recent, and we are working on publishing our result as soon as possible. During the ICU care stay, there is nothing much special regarding CTD patients, and you know all those guidelines recently published focusing on mechanical ventilation, neurologic dysfunction and its prevention, antimicrobials, and hemodynamics. And please let me insist on the difficulties in some patients to use vasoconstrictors regarding the risk of digital ischemia here. Few words on the PGD and ECMO in these patients. You know that with the presence of pulmonary hypertension or the presence of pulmonary fibrosis in the context of sometimes oversized allograft, your patients with CTD will be at a higher risk of primary graft dysfunction. So in this setting, ECMO is very interesting. Obviously, for treating pulmonary graft dysfunction, but also sometimes to bridge the patient to transplant during the pre-transplant procedure, or during the surgery itself, or post-operatively, because just after the surgery, your patient remain unstable. And using ECMO will expose your patients to classical complications that everyone is aware of here: bleeding, thrombosis, or infection. But in our experience and based on quite limited data, there is no strong signals that patients with CTD will face higher risk of ECMO complications. few words on the post-operative management, which is quite challenging too. For any reason, your patients after the transplant will be at higher risk of needing an enteral artificial food or alimentation. So on the left, you see the routes that are usually accepted to be used. In the absence of GI tract involvement or severe GI tract involvement, placing a nasojejunal tube is pretty acceptable. Or if you know before the surgery that your patient is having a mild esophageal dysfunction, we usually perform in our center a jejunostomy tube placement during the surgery. And then it will be avoidable very quickly to provide enough calories for your patients. On the right, you see that gastrostomy is usually discouraged because it is associated with a higher risk of worsening of gastroparesis. So we don't use gastrostomy here in these patients. Here, two additional approaches that could be interesting, particularly in the presence of a refractory gastroparesis. The first one is endoscopic pyloromyotomy that has been associated with benefits in terms of improving gastroparesis symptoms or the gastric retention as described here. And the second one is the gastric electrical stimulation, which could be used maybe in addition to pyloroplasty. However, there are very, very few results, or very few data on that technique in the literature. And in our experience, we used this procedure in less than 10 patients with conflicting results. We can discuss that later if needed. So last part of the presentation during the last 3 minutes, outcome in our patient transplanted for CTD disease, you see summarized here the main data on CTD-ILD, and one of the most striking of it is that it's only observational, retrospective with limited number of included patients. That being said, there is no strong differences in terms of outcome regarding survival, rejection, or CLAD in our patients transplanted with CTD compared to other indication. What about the infectious risk in CTD patients? The main risk is related to the intensity of immunosuppression. Andrew discussed that already, and this is particularly true here, in addition to other factors. And there may be a cumulative risk of pre-transplant immunosuppression. However, we need further prospective studies to clarify this risk. What about cancer? Cancer is also mainly driven by chronic immunosuppression, but in our patients, there is no current evidence indicating a higher risk of cancer incidence after transplantation. I will end with this slide showing a recent initiative dedicated to the most severe patients we need to deal with. On the right side, you see the result of a new procedure we created. It's a multidisciplinary board dedicated to patients with CTD and a rapidly progressive ILD. And you see that over a period of 26 months, 26 patients were discussed. Those patients were very severe in terms of ICU, mechanical ventilation, or ECMO. This patient had mainly MDA5 phenotypes, And in 70% of them, we were able to discuss transplant, leading to either listing them or transplanting them in more than 25%. So this approach is very, very nice. And on the right side, you see the results that has already been discussed earlier of our European study on myocytic patients with myopathy. And you see that patients which are the most severe in this study, 21 of them were a bridge to transplantation in a very, very severe situation. And you see that this high priority program was associated with a pretty acceptable result for transplantation. So multidisciplinary discussion that can be convened anytime in addition to priority program will help clinicians to bridge the most severe patients with acceptable results. So I will stop here, remembering everyone that CTD transplantation is challenging and should be performed in expert centers. The results are pretty acceptable according to a strict selection process. However, we still need to improve in some areas, particularly the management of the GI tract in these patients. Thank you so much.
Thank you, Jerome. And thank you, Dr. If there is any question from the audience, again, please write it down in the chat. Aida, do you want to start some questions?
That was great. Thank you very much, Dr. Lepavec. So my first question is for Dr. Gross. I mean, with the complexity that you show us about kind of myositis and the different biologic agents, what is your particular approach to selecting agents to control myositis?
Glad you asked. All right. Okay. All right. So there we go. Okay. All right. So here, so me and my colleague, Dr. Shaw, went through this, thinking deeply about this and talking with our colleagues. And I'm going to talk a little bit about our approach at UCSF. So this is for dermatomyositis antisynthetase syndrome. And the key thing here is that there's many different manifestations of disease that's different in different patients. So it really is tailored to patients' disease manifestations. So of course, there's the lungs, there's the myositis, there's the cutaneous manifestations of their disease, and of course, some patients have arthritis. So our first line treatments, of course, are glucocorticoids, but then we often are turning to mycophenolate and IVIG, especially in the context of interstitial lung disease. The bold indicates that we have randomized control trial data, although it might not necessarily be from myositis. So in the case of mycophenolate, that's more from the scleroderma literature. But it is, of course, quite effective for the lungs, good for the muscles, good for the skin, not as good for the joints. And then we're frequently turning to IVIG, less relevant from a lung standpoint, but the ProDerm study was a randomized control trial data for dermatomyositis of IVIG, showing that it's quite effective for the muscle and skin inflammation. Works very quickly and seems to be quite safe. There is an increased risk of thrombotic disease, DVTs, and of course, patients can get headaches. But it does seem to be quite safe with no increased risk of infection, and that's my sense of it post-transplant as well. So that is a good alternative, although of course it's not going to help for the lungs as much. Okay, so then our second line, we tend to return to rituximab. We have a randomized control trial data for muscle involvement. Technically a negative study, but I think that was part from the study design. People think highly of this medication for treating muscle disease. Potentially it's helpful for the lungs. We have good data from at least one study in scleroderma and another one comparing it to cyclophosphamide. Doesn't seem to be as effective for the skin. So if a person has a dominant skin component, it might not be what we turn to. And then quite effective for the joints shown in rheumatoid arthritis. I'm not going to spend too much time on nintedanib because, of course, it's not effective for autoimmune disease. It's more for the fibrosis. And then our third line, and I'm sure some people on here will bristle as I put tacrolimus all the way down lower, but we just don't tend to use it as much at UCSF. Of course, it's helpful for the lungs, might be helpful for the muscles, seems to be good for the skin, and may be good for the joints, although we really don't have very good randomized controlled trial data looking at tacrolimus. Um, Tofacitinib, we're turning to more and more. We're all eager to see a big randomized controlled trial is being done right now with a combination JAK and TYK2 inhibitor. There's a lot of promise here. Um, Seems to be already quite effective for the joints and rheumatoid arthritis. Time will tell about these other things, but it seems like it's going to be quite effective for muscle disease and skin disease and dermatomyositis. But as mentioned previously, infections are a real concern. Tocilizumab, of course, very effective for scleroderma ILD, but it actually has no benefit on the muscles or the skin. So in these patients, we're using it considerably less frequently. And then finally, medications that we rarely use, cyclophosphamide. Occasionally, of course, we'll use when we're desperate, since it is really the go-to, but the toxicity is quite limiting. So that's the way I think about our use of all these different diseases, mixing and matching. And then I already alluded to some of the problems that you run into post-transplant.
Thank you much. That was quite insightful.
That's
Thank
worldwide.
you. Yeah. I have a question for Dr. Lipovec. There was a lot of mentioning about GI challenges, especially for this patient with CTD-ILD and scleroderma in particular. You mentioned pre-transplant, post-transplant kind of assessment. So what kind of perioperative strategies you in your center you use to mitigate the risk of aspiration and GI complication?
Yeah. So based on the workup that I have described, usually it's in the presence of GERD, for example, it's hard to have a pre-op strategy for surgery because patients are pretty severe at the time of referral. So what we do is based on the workup and the results of the workup, normally your patients won't have any gastroparesis because otherwise they would be contraindicated. They may have esophageal dysfunction. They will, in a large proportion, have aperistatism, more than 80% of them at the time of referral. So depending on the severity, you would either contraindicate them or accept the risk for transplantation. And then, as I said on the slide, if you are aware of this esophageal dysfunction, I think a strategy based on surgical jejunostomy at the time of the surgery is the right thing to do. It's not adding so much to the surgery, so it's quite acceptable. It's to do it in the same time. And sometimes, unfortunately, you didn't have gastroparesis before the surgery, but your surgery is worsening this situation, and gastroparesis may appear afterwards. So then you have to move to second line approach, pyloroplasty, maybe, and on a case by case discussion with a specialist.
Thank you.
And it looks like we have another question on the chat. I think the first one for Dr. Cross, the second for Dr. Lipovec. The first one is, do you keep myositis patients on more than the standard 3 immunosuppressants? So if you can just comment on your post-transplant rationale for keeping them on augmented immunosuppression.
Yeah, Dr. Venato and I instantly think about a patient that we shared together. Bottom line is that you keep them on whatever maintains control of their myositis. So for some patients, it's not much. Maybe it's only 2 drugs. Maybe it's only mycophenolate and IVIG, and that's really easy to maintain post-transplant. For other patients with much more severe disease, we've actually maintained people on mycophenolate, IVIG, rituximab, and maybe a little bit of steroid. So it's just whatever you have to do. Of course, rituximab post-transplant, we worry more about, although the patient that Dr. Minato and I share doing great. So you never know.
Yeah, and I think the second question probably both can answer because maybe before and after transplant management. What is the management for patient that has scleroderma and bowel dysmotility, maybe presented with, weight loss or challenging in nutritional? Is there any specific approach that you have, any medication that you use for those patients? Jerome, yeah, go first.
Yeah, so can you repeat again the complication we're
For
talking about?
for patient with bowel dysmotility, if they're having nutritional challenges like gaining weight, um,
No, yeah, it's hard to deal with. We have a multidisciplinary approach, obviously, combining nutritionists and specialists on that. Maybe all those patients will be under prokinetics, and we will be dealing with the root of we can provide nutrition, but it's on a case-by-case basis. It's pretty hard.
Maybe I'll chime in to say that there's like 20-year-old data that in people with scleroderma who are losing weight, that is a bad prognostic sign. And you really should be worried about those people.
yeah, perfect.
I just wanted to make a comment on immunosuppression
Hmm.
because there is a very crucial situation is the patient with myositis out of the blue having a severe ILD. And sometimes clinicians that don't know what is the best option and how far they should go with immunosuppression. So my comment here is just to say that you need to know if transplantation is possible. If yes, I think you shouldn't go too far and do your best to bridge these patients to transplantation. This is my only comment.
I totally agree. I think there is especially, looping in with the slide presented by Dr. Gross, the use of cytoxin. I don't think we have great data showing, but in acute exacerbation scleroderma or like the survival of cytoxin is pretty miserable. And so I think we should definitely look prior into is there a patient that can get a transplant. Yeah, I agree with those comments. Any other?
Completely agree. Completely agree.
Yes, and one final question that from the audience, Dr. Gross, I don't know if you can comment a little bit on the MTA5 clusters. I guess that clinical variability of rash and myasthenia versus lung involvement. Do you think there's a potential pathological or biologic mechanism that is different to account for these three clusters? Or any way to identify them prospectively as we think who should be referred for transplant early versus trying immunosuppression longer?
Yeah, it's a good question, and I struggle with all this. I struggle with the significance of these clusters. I think we all know right away who the patient is who has rapidly progressive ILD. Um, Jerome's discussion about their approach with this multidisciplinary group, looking at these specific group of patients, regardless of the diagnosis, underlying diagnosis, these are just going to be a really hard group of patients to care for. And yeah, being forced into transplant and everything happening so fast makes it extremely difficult. Trying to identify these ahead of time, boy, that's tough because everything's happening so fast. So I don't think I have a good answer for that one.
All right. I think we had a very good discussion. Any other question? Otherwise, I think we can close the webinar. Thank you again, Dr. Gross and Dr. Lepavac. And thank you, Aida, for helping and Juliet for helping for the webinar and everybody in the audience. We'll see you for the next time. Thank you.